Okay, good morning. I would first like to thank the committee for giving me the opportunity to present the study at this meeting. My name is Samir Al-Masri, and I'm a postdoctoral fellow at the University of Pittsburgh Medical Center, and we have nothing to disclose. Now, we know that Roux-en-Y gastric bypass is one of the most commonly performed bariatric operations in the United States. It entails alteration of the normal luminal anatomy, which renders conventional access to the biliary tree technically challenging. This is confounded by the fact that these patients are predisposed to develop various biliary tract disease secondary to the rapid and effective weight loss that they experience. There are various access techniques that are used to overcome these anatomic hurdles, starting with the deep peroral enteroscopy techniques, such as the spiral enteroscopy and the single and double balloon enteroscopy. Although these techniques are minimally invasive and associated with low complication rates, their technical success rate is suboptimal owing to the rule limb length and forward viewing duodenoscopes or endoscopes. The US-guided transgastric ERCP is a recently introduced technique which has technical success rates similar to the lap-assisted ERCP. However, it entails creation of a transluminal gateway between the efferent limb and the remnant stomach, and it requires time before the tract to mature, so it cannot be used in emergency setting. This is where the utility of lap-assisted ERCP emerges. Lap-assisted ERCP provides laparoscopic access to the biliary tree through the pylorus. It can be used in emergency setting as it's a single-stage procedure. It allows the utilization of conventional ERCP equipment, thus the high success rates and the low adverse events rate for this surgical modality. The aims of our study were to determine the learning curve for this commonly performed operation at a high-volume pancreatobiliary center, but we also wanted to describe our own institutional experience and patient outcomes. In order to answer these questions, we performed a retrospective review of all lap-assisted ERCP cases performed at our institution after 2007. We collected information pertaining to patient demographics, operative ERCP variables, and patient outcomes. We used non-parametric descriptive statistics to describe our patient population, and both QSUM analysis and individualized surgeon experience were used to determine the learning curve for this operation. We identified 131 patients with a median age of 60 years and 81% were females. The surgery was performed by a group of 17 surgeons and 10 gastroenterologists over the study period, and 62 cases had a concomitant cholecystectomy performed at the time of the lap-assisted ERCP. The Roux-en-Y gastric bypass was laparoscopically performed in 91% of our cohort, and the median time between Roux-en-Y gastric bypass and the lap-assisted ERCP was around 7 years. In terms of patient demographics, the median Charlson age-adjusted Charlson comorbidity index was 3, and the patients of our cohort had a median percent decrease of BMI of around 35%, and this is important, I'm going to show you in the multivariate model. In terms of indications for lap-assisted ERCP, as we would expect, the most common indication was cholelithiasis in 78%, followed by sphincter of Oddi dysfunction in 18%, followed by 2.3% for each management and diagnosis of a malignant biliary stricture or management of a bile leak following cholecystectomy. 42% of our cohort actually presented with acute cholangitis or pancreatitis at the time of presentation. In terms of operative variables, the median surgical time was 128 minutes, while the median ERCP time was 48 minutes. The success rate of ERCP, which is measured by the successful cannulation of the papilla, was achieved in 100% of our cohort. And the conversion rate in our cohort was 11%, which is slightly higher than that reported in the literature. And the most common reason for conversion were intraoperative adhesions, intra-abdominal adhesions. On multivariate analysis to identify the predictors of conversion, we found a history of multiple abdominal operations other than Roux-en-Y gastric bypass significantly increased the risk of conversion as you would expect. But interestingly, we found that the percent decrease in BMI also increased the risk of conversion, and this effect was independent of the timing between the Roux-en-Y gastric bypass and the lap-assisted ERCP. In terms of outcomes, serious complications as measured by a Clavien-Dindo score of more than or equal to 3 developed in 6% of our cohort. The most common complication was a surgical site infection developing at the 15mm trocar site that is used for endoscopic access in 9%. And the incidence of ERCP-induced pancreatitis was 4%, which is similar to that seen in conventional ERCP. The median length of stay was 3 days, and the patients were followed up over a median of 43 months. Now, in order to determine the learning curve, the QSUM analysis, which is a valid statistical method that graphically depicts the cumulative sum of differences from the total cohort's mean in response to several metrics, was used to determine the learning curve for the institution as a whole. However, since the study involved 17 surgeons, using QSUM analysis would be futile to determine the individual learning experience. So we performed a surrogate analysis where each individual surgeon caseload was divided chronologically using several binary cut points. And the cut point that reflected the most significant improvement in several perioperative metrics was chosen as the cutoff to represent the learning curve for this operation. And then the individual surgeon cutoff point was then compared to the rest of the surgeons involved in the study. As you can see in this graph of the total operative time plotted against the cases in chronological order, the shaded area in the curve represents the cases without concomitant cholecystectomy during the lap-assisted ERCP. And you can see a statistically significant decrease in operative time along the study's cohort. The cases that are not shaded are the cases with concomitant cholecystectomy, indicating that the time was very haphazardous, and that's why they were excluded from QSUM analysis. This is a QSUM curve for the surgeons. You can see a clear inflection point after case 27, where there was a statistically significant decline in operative time. We had a similar curve for the gastroenterologist group of the operation, and the inflection point was seen after case number 10. I didn't include the graph just for the sake of time. For the individual surgeon learning experience, the cutoff that demonstrated the most significant improvement in perioperative metrics was 1/5 in each individual surgeon caseload, which reflects the first, on average, 3 to 5 cases of each individual surgeon. We noticed a significant decline in operative time, or the actual surgical time. And although there was a decline in the conversion rate, readmission rates, and overall complication rates, none of these reached statistical significance owing to the small sample size of our study. As you can see in this graphical presentation for the operative time, when we lumped the early 1/5 experience of all the surgeons of our cohort and compared it to the late 4/5 experience of the surgeons, you can see a statistically significant decline in the mean operative time for our patients. So in summary, lap-assisted ERCP is associated with high success rates and low adverse event rate. The learning curve for the institution as a whole is expected after case 27 for surgeons and case 10 for gastroenterologists. And for individual surgeons, the expected learning experience is seen after the first, on average, 3 to 5 cases. Our study has several limitations inherent in retrospective study design. We had a low sample size, which translates to low effect size for comparison, and there is significant heterogeneity in the surgeon's timeline and individual experience. However, we can still conclude that lap-assisted ERCP is a safe and feasible procedure for the treatment of various pancreatobiliary pathologies following Roux-en-Y gastric bypass, and is associated with high success rates and low adverse event rate even in the early phases of experience. On average, 3 cases may be considered as a learning curve for lap-assisted ERCP, after which the efficiency and surgical outcomes are expected to improve. Thank you very much.
Great job, 7 minutes and 30 seconds.
Thank you.
Way to go. We have as our first discussant, Dr. Philip Plaatke from Belgium. Again, please.
First, let me congratulate with your presentation. It was a nice presentation, very detailed and with a lot of information. So my first question is, so your analysis indicates that the laparoscopic assisted ERCP procedure is quite easily performed with a short learning curve in comparison to other techniques. Would you suggest that this procedure is used in all hospitals or only university or academic hospitals in tertiary centers? Or because it's quite easily to perform or it has a shorter learning curve and the success rate is a lot higher. So for example, the balloon assisted endoscopy with ERCP, the success rate in literature was around 60%. So would you say that every hospital should use it?
Well, this is a great question. What you can see from the literature is there are multiple single center retrospective studies, and there are a couple of large meta-analyses that looked into this. So the success rate of lap-assisted ERCP in not dissimilar in our institution, basically, in any other institution was more than 90% at least, which is similar to the EDGE. So in our institution, the problem is it's a high volume pancreatobiliary center, but involved 17 surgeons, which included also a significant number of general surgeons. And you can see the success rate was almost 100%. Now, we measure the success rate by cannulation of the papilla. Of course, if you can measure it by complications or conversion, it will be much lower than that. But it is an easily reproducible procedure, and the statistical method that we use to determine the learning curve are valid. So this is what would be expected to be generalized, basically.
Okay. And a second question I had was your trocar placement, because one of the things when I looked it up was that the trocar and the endoscope, when it passed, that it removes some of the flexibility of the endoscope. Was that also a part of the learning curve? Was that the trocar placement, or?
Actually, it shouldn't be a problem because it's a straight path toward the pylorus. So usually you place a 15mm trocar at the anterior axillary line on the left side, and the endoscopist can easily go through the pylorus. Of course, we had some cases where we experienced significant difficulty in manipulation, and this is where we needed to convert. But that's the advantage of it. It provides the endoscopist with easy access to the pylorus.
Okay.
Other questions?
Yeah, that's most of my questions are answered. Thank you.
Thank you.
Other questions? Anyone? So Samir, this will be the question, is endoscopic sphincterotomy routine when this is done for the purposes of both stone clearance, but also the, I think, pretty well recognized now incidence of late ampullary stenosis for these patients that can be quite painful as a preventative measure for that?
Yes. Actually, in 98% of our cohort, a sphincterotomy was done. While the remaining almost 7% patients had a metallic stent placed for management of a malignant stricture, and almost 85% had a stone retrieval for cholelithiasis. But sphincterotomy is almost always done, as you said.
Okay, any further questions? Well, thank you and congratulations.
Thank you so much.